how do we assess whether it's a lid ptosis or a brow ptosis? And second part, for technical reasons I'm asking that in orbital fractures in college we used to take ophthal examination and consideration, just in review. So in these cases where we are expecting there is a ptosis, where we can see and we are explaining the patient, do we or do we not take an ophthal examination into consideration for this?
Ideally, yes, you should get, if you're doing a ptosis correction, you should get an ophthal review with you. Another part, what happens in ptosis is because you're changing your aperture of the opening eyes. So if a person is wearing glasses or prescription glasses, so prescription glasses are also attached with the aperture also. So once the aperture goes up, so patient may actually feel a little difficulty in the vision, because when they look up, because the aperture is bigger, the glasses were not meant for that kind of aperture. So sometimes they may have blurries in the peripheral vision when they move around. So you have to tell these things to your patient before during consultation.
15 questions, 15 minutes.
Yes, ideally you should get an ophthal.
One question, 1 minute. Somebody should stand with this Cadbury's.
Lid ptosis and brow. See, brow ptosis, what I do is normally is that I told you, the above part. The lid ptosis is basically the opening of your superior margin. How far is it from your superior limbus? Okay, so ideally in a normal case, it should be like covering maybe around 1 or 2 millimeters of the superior limbus. Anything lower than that, that means there is certain amount of ptosis. No.
Okay.
When you look straight forward. So when you have a little bit of ptosis, if it is down, it's almost like touching the, it's covering like 3, 4, 5 millimeters of your lateral the iris. It has ptosis.
Okay. Thank you very much. So the first question what I have put here is, which nerve supplies the motor innervation of the levator palpebral superioris? Anyone? Oculomotor nerve. So if the oculomotor nerve is injured, what do we have? Ptosis, right? So my question is, when I am working in a neuro unit, in a very big neuro unit in Kolkata, we get a lot of trauma patients coming with ptosis and sometimes with known as pseudotosis. So when a patient has got a ptosis and a pseudotosis together, how do you differentiate it's a ptosis or a pseudotosis? Ptosis is caused by the injury of the oculomotor nerve, right? What is pseudotosis? How do you differentiate between a true ptosis and a pseudotosis in a patient having trauma? Anyone?
If there is a lead lag, it is a pseudotosis.
Laxity.
Laxity of a lead or a lead
No,
lag.
I have told a patient has come with a trauma, mid-phase trauma, and you proceed from here. You go and see the patient has got a ptosis, right? So how do you investigate this patient? Has got a ptosis due to a cranial nerve injury or ptosis due to a blowout fracture of the orbit? How do you go about it? So, because the oculomotor nerve supplies the Muller's muscle of the levator palpebral superioris. So you please proceed from here. Rahul?
Yeah, so what I would, this is not a rehearsed session for us, but the other muscles are also there, the 3rd, 4th and 6th. There will be ophthalmoplegia. So look for other muscles also. Generally, only ptosis is not a thing. The patient will have total ophthalmoplegia most
Yes,
of the
right.
situation.
They will have midriasis.
In the midriasis.
And we put a forceps and tap them.
No, the thing is you have to see for a midriasis when there is a oculomotor nerve palsy, right? So which structures provides the main structural support to the upper eyelid? Who said? Okay, right. One chocolate, that's it. No, still back.
Did everybody understand the first question? Answer: midriasis, meiosis, midriasis. Dilatation. Okay, the pupil will be dilated. There will be vision. Okay, and as I said, there will be ophthalmoplegia. 3rd, 4th, and 6th nerves will be there, so patient will not be moving the eye at all.
Yes, right.
Another complication. What worse can happen in that situation after a superior orbital fissure syndrome? Anybody? Orbital apex syndrome, or optic nerve atrophy, orbital apex syndrome, and most of the times SFAF syndromes are self-correcting.
Orbital apex syndrome may cause blindness.
Yes.
Optic
Yeah.
nerve involved.
So what is the main blood supply of the upper eyelid? comes from the branches of the ophthalmic artery. True? Ophthalmic artery is a branch of
Internal carotid artery.
artery. So, as Rahul showed in his video very well, the lacrimal gland is located where? Who is saying this?
The lacrimal gland
Achha,
is
theek hai, chocolate.
Posterolateral.
Right. So let us identify this anatomical structure. Rahul has sent me this 2 days back. So they can do orbital surgeries, right? Right.
Guys, here, no, people are looking at their phones. Don't do that, na? You can do that at home also.
Achha, can I ask one more question?
Yes.
We are discussing. In terms of canaliculus, if there is a canalicular injury, what would you do? Anybody? No, immediate. Immediate.
We can repair the canal.
Yes. Yeah. Using.
Take a mic.
We
And
can
if
repair the canal.
now, okay.
Yeah. So during our residency days, we would pass in a 1-0 proline, but now there are stents.
Yes.
Yes.
Mini monoca stent. You can stent under microscopic vision, okay, or loop vision.
People from behind have to answer.
And-
now. Till here, nobody answers. Okay?
Which is more important, the upper or the lower canaliculus? Now it's the lower. 80% of the drainage happens from the lower canaliculus.
Wake up, huh? People behind.
Right. So transconjunctival approach has got a very potential of globe injury. People try not to do this because they think that the globe will be injured. It is true or false? Pratik, where is Pratik?
Unless you have an assistant who is in Cisco.
Okay. So transcutaneous drainage approaches has got a comparatively high incidence of ectropion. Is it true?
Yes.
Right? But after this gear, I don't think it will be. You know how to repair it now. Only the skin, not the muscle. Right? Right?
So, is the subcutaneous suture better than on intravenous?
See, listen.
Nikha.
This is not a discussion between you and them, okay? It is something to help everybody. So if anybody wants to say anything, please use the mic. Here, there, anywhere. Okay? It's not a one-to-one discussion. And this is a class, okay?
Okay. So she is asking that is subcutaneous suture, subcuticular suture is better than your intraoptic suture, right?
For the subsidiary.
For subciliary incisions.
I would prefer it. So, I use intractic, because it doesn't have much fat, as Dr. Anatomy was told. So I prefer to give nothing much to hold it. And the stitches really don't give a scar. There are a lot of lines coming there.
Other is again, if you're only a skin flap, it's nothing to hold on to, and subcuticular strangles the cutis. If you think about it, subcuticular strangles the cutis, so that's a disadvantage.
So we have discussed recently what is the oculocardiac reflex, trigeminal reflex. Now you know that, right? If you overstretch the muscle, there will be a certain bradycardia. So as sir told that you have to talk to your anesthesiologist when you are manipulating the orbit, right? There's nothing much in it. So what is this anatomical structure?
No, put up your hands. That's it. Yes.
Lacrimal gland.
Is the lacrimal gland?
No. Did you give me one
If you
back,
see
something back from
Rahul's
this?
video, then you can. He has told this several times, 2 times in the morning. What is that?
Hands.
What is this blue color? This one. Horner's muscle? No. This is a palpable part of the lacrimal gland. Okay. So he sutured that, right? And he tried to put a lacrimal gland behind. Is it so? No, right. What is this approach? Transconjunctival, how mentioned that certain distance should be maintained from the okay. So what are the types of subciliary incision we just discussed and what we are following? 3 types. Fine. So just I'll run through the cases. Any one of you, what will be the best approach for this case? I've got orbital flow, infraorbital rim and a FZ fracture. Don't talk about the zygomatic buttress. That we'll do intraorally. If you want to do is a 20-year-old boy had with a mica accident, has got enophthalmos, orbit, infraorbital rim and FZ. Pardon? Anyone?
One person. One.
Transcon with lateral catherectomy. Everybody agrees. Rahul. The speak.
She disagrees.
Yeah, I
Should-
will use bicoronal approach for this.
Bicoronal? Okay, you're talking about the FZ. No, don't go about the FZ. We are not into reduction of zygote. I'm just talking about. See, think that there is no arch fracture, only FZ orbital flow, right?
FZ and
गिनना है कि नहीं गिनना है?
हाँ, FZ गिनना है. FZ orbital flow. Okay, so there is no two incision, right? Subciliary upper left no. Okay, great. Thanks.
He also has a existing laceration.
Yeah, that's right.
So, but if he
So-
didn't have it, still wins.
Right. So this patient again has got a infraorbital rim blowout, infraorbital rim fracture with the orbital blowout. No, I'm talking about the infraorbital rim and orbital blowout. See the city? Subciliary? Or?
Transcontinental level without endotomy.
See what sir told that if you can do a proper infraorbital rim incision, see here. He has got a skin crease, right? You can use as a beginner, you can use a proper infraorbital rim also. Incision if you can close it properly. So sir told that a good infraorbital rim is better than a bodged up transconjunctival initially when you are starting, right? Right. So plication is done on the upper eyelid with what? So sir was showing when he was doing a blepharoplasty, upper eyelid blepharoplasty, he was putting some sutures for plication for the levator there. So what sutures he was using? Bicual? They're hearing, not sleeping. Okay, right. Last one. Okay, what is this suture?
Cross suture, see there are two these things. One is to open and see whether vision is there or not.
Right.
The cross suture and forget suture
This
now
is
there.
what I do. I put two micropore. I open this and ask the sisters to give drops and also to see the vision. Right?
It should not be a forget suture.
Yes.
3 दिन के बाद देखेंगे.
So quickly, anyone? What is this muscle here? Mullers? Horner's muscle. Right. So we dissect between the horners and the orbital septum here so that the lacrimal sac doesn't get injured. So what is this rule of half? 24, 12 and 6. This is the orbit and this is your medial wall. What is this? What is this? What is this? Quickly. So this is what? Where I'm pointing. What is this? So here is the. So what is this here again? And here? Right. Fine.
We never see the posterior ethmoidal artery ever in trauma.
Yes.
Otherwise the patient is blind. You only see when you are doing orbital resection.
Yeah, this is the last one. What I am doing here, the patient has undergone orbital surgery. What I am doing here, that is very important, right? Any orbital fractures you do, you should do for a force duction test, right? And keep it as a video, medically.
Can I just 2 minutes? 2
Yeah.
minutes. Important point. So
Yes.
you do this not only for orbital fractures, you also do it pre and post zygomatic reductions. Because post reduction also you can have an entrapment, and I have an unusual case of a. Anyways, that is not for this.
Keep it as a video because medical is very important. Thank you.